Dear student, Assalamu alaikum. This is the second lecture in the renal system in which we are going to discuss acute kidney injury in addition to urinary tract infection. Acute kidney injury, it is a clinical syndrome in which there is a sudden deterioration in the renal function, result in inability of the kidney to maintain fluid and electrolyte hemostasis. And acute kidney injury characterized by the following: increase in the serum creatinine by more than or equal 0.3 mg per deciliter from baseline within the 48 hours, or increase in the serum creatinine to more than or equal 1.5 times baseline within the prior 7 days, or urine volume less than or equal 0.5 ml per kg per hour for 6 hours. As you know, the normal serum creatinine is ranging from 62 to 124 micromole per liter, while the normal blood urea ranging from 3.23 to 7.5 millimole per liter. Pathogenesis. According to the cause, acute kidney injury classified into 3 categories: pre-renal acute kidney injury in about 55 to 60%, and the cause include dehydration, hemorrhage, sepsis, hypoalbuminemia as in case of nephrotic syndrome, and cardiac failure. Second, intrinsic renal acute kidney injury in about 35 to 40%. Causes include glomerulonephritis, like acute post-streptococcal glomerulonephritis, SLE, inoculum purpura, membranoproliferative glomerulonephritis, in addition to hemolytic uremic syndrome and renal vein thrombosis. Third, post-renal acute kidney injury in about 5% of the case, and the cause include posterior urethral valve, uretropelvic junction obstruction, uretrovesical junction obstruction, urethrocoel, stones, tumor, and neurogenic bladder. Clinical manifestation. Carefully taking history is critical in defining the cause of acute renal failure. In case of diarrhea and vomiting, which result in dehydration and pre-renal acute kidney injury, while recent history of pharyngitis with periorbital edema, hypertension, and gross hematuria suggests intrinsic acute kidney injury may be related to acute post-streptococcal glomerulonephritis. Critically ill child with hypotension and exposure to nephrotoxic drug like aminoglycoside, the most likely diagnosis is acute tubular necrosis. Male neonate with history of hydronephrosis on pre-renal ultrasonography with palpable bladder, the most likely diagnosis is posterior urethral valve. Physical examination. In case when there is a tachypnea, dry mucous membrane, and poor peripheral perfusion, this suggests inadequate circulation and pre-renal acute kidney injury, while when there is a peripheral edema with rales and cardiac gallop, this favors diagnosis of volume overload and intrinsic acute kidney injury. Presence of rash and arthritis may suggest SLE or inoculum purpura, while the presence of palpable flank mass may occur in renal vein thrombosis, tumor, urinary tract obstruction. Lab finding. First, complete blood picture, anemia, and anemia usually dilutional or hemolytic, as in case of SLE, hemolytic uremic syndrome, and renal vein thrombosis. Leukopenia in case of SLE, thrombocytopenia in case of SLE, renal vein thrombosis, and hemolytic uremic syndrome. Second, electrolyte. There is hyponatremia, usually dilutional. We have also hypocalcemia, increase the serum uric acid, potassium phosphate, and this is due to diminished renal function. Blood urea and serum creatinine usually elevated with metabolic acidosis. There is also decrease in C3 level in case of SLE, post-streptococcal glomerulonephritis. General urine exam may show hematuria and proteinuria, which indicate intrinsic acute renal failure. Management. First, nutritional management. And acute kidney injury represents a very catabolic state. The goal of nutritional management is provide adequate calories, low protein, low potassium and phosphate, and decrease fluid intake. Fluid management. We have two situations. The first, when the patient has dehydration or shock. Intravascular volume expansion by intravenous isotonic saline 20 ml per kg over a period of 30 minutes. Severe hypovolemic patient may require additional fluid bolus, and hypovolemic patient usually void within 2 hours. Diuretic therapy should be considered only after adequacy of circulating blood volume has been established. Furosemide in a dose of 2 to 4 mg per kg may be administered as a single intravenous dose. If urine output not improve, then a continuous diuretic infusion may be considered. To increase renal cortical blood flow, many clinicians administrate dopamine 2 to 3 microgram per kg per minute, accompanied with the diuretic therapy. If there is no response to diuretic challenge, diuretic should be stopped and fluid restriction is essential. Second situation, when the patient has established renal failure with volume overload. In this situation, the fluid restricted to insensible water loss 400 ml per meter square per day plus the urine output. The type of fluid is glucose water 10%. Complication of acute kidney injury. Complications include hyperkalemia when the serum potassium level more than 6 milliequivalent per liter and is presented with muscle weakness, cardiac arrhythmias, and ECG changes. This figure will show the changes in ECG that occur in hyperkalemia. There is a peak and tall T wave, prolonged QRS complex, prolongation of PR interval with diminished B wave, and prolonged QT interval. Treatment of hyperkalemia include elimination of exogenous source of potassium with continuous ECG monitoring, sodium bicarbonate 1 to 2 milliequivalent per kg intravenously over 5 to 10 minutes, calcium gluconate 100 mg per kg per dose, maximum 3 grams per dose, intravenously over a period of 5 to 10 minutes with ECG monitoring. Also, we can use regular insulin 0.1 unit per kg with 50% glucose 1 gram per kg over 1 hour. Sodium polystyrene sulfonitrazine 1 gram per kg given orally or as a rectal enema and may be repeated every 2 hours. This will exchange potassium for sodium in the colon. All these measurements will result in decrease in the serum potassium level by shifting of potassium from the extracellular compartment to intracellular compartment. And lastly, for persistent hyperkalemia, may be managed by dialysis. Hyponatremia. Hyponatremia can be treated by fluid restriction, administration of hypertonic saline 3%, for symptomatic hyponatremia which present as seizure and lethargy, or if the serum sodium level less than 120 milliequivalent per liter. Hypocalcemia can be treated by lowering the serum phosphorus level by low phosphate diet and oral phosphate binder like calcium carbonate and calcium acetate. Anemia. Anemia, as mentioned, could be delusional or as a result of hemolysis and can be treated by blood transfusion if the HB less than 7 gram per deciliter. We usually use packed RBC 10 ml per kg given slowly over 4 to 6 hours to diminish the risk of hypervolemia. Indication of dialysis. First, when there is a volume overload with hypertension and or pulmonary edema refractory to diuretic therapy. When there is persistent hyperkalemia, as mentioned previously. When there is severe metabolic acidosis and responsive to medical treatment. Also, when there is a neurological symptom as seizure and altered mental status, anuria and oliguria, and lastly calcium phosphorus imbalance with hypokalemic tetany. Hemolytic uremic syndrome represent a type of acute kidney injury. This syndrome is a common cause of acute kidney injury in young children and characterized by the following: microangiopathic hemolytic anemia, thrombocytopenia, and renal cortical injury. Etiology: this disease most frequently follows episode of gastroenteritis caused by Shiga toxin producing enterohemorrhagic strain of Escherichia coli, O157H7. These microorganisms elaborate Shiga toxin, which absorb from the intestine and initiate endothelial injury. Other infection is less commonly associated with hemolytic uremic syndrome, which include bacteria like Shigella, Salmonella, and Campylobacter, viral infection like influenza and HIV. Some of drug can be cause hemolytic uremic syndrome, like cyclosporine, metramycin, and quinine, systemic disease like SLE, and malignant hypertension, in addition to radiation nephritis. Clinical manifestation: this syndrome is more common in children less than 4 years of old, and the onset usually preceded by gastroenteritis, often bloody, and less commonly by upper respiratory tract infection. This follows in 5 to 7 days by sudden onset of pallor, irritability, weakness, lethargy, and decrease in urine output. Physical examination will reveal presence of edema or dehydration, petechiae, and hepatosplenomegaly and marked irritability. Diagnosis: complete blood picture will reveal microangiopathic hemolytic anemia. HB level is ranging from 5 to 9 grams per deciliter. Blood film will reveal helminth cell, schistocytes, and fragmented RBC, with elevated red count and thrombocytopenia. And this is the blood film of patient with hemolytic uremic syndrome with abnormal RBC, helminth cell, and fragmented RBC. Urine analysis may be show microscopical hematuria and low-grade proteinuria. PT and PTT usually normal, COMT test is negative, and renal function test usually elevated, which indicate renal involvement. Differential diagnosis include other causes with microangiopathic hemolytic anemia and thrombocytopenia, and include lupus nephritis, malignant hypertension, and bilateral renal vein thrombosis. Complications include anemia, acidosis, uremia, hyperkalemia, hypertension, and heart failure, sometimes colitis, and intestinal perforation, and lastly CNS manifestation like irritability and seizure. Treatment: supportive care, including careful management of fluid and electrolyte, control of hypertension, and early institution of dialysis if the patient become anuric or significantly oliguric. Wash RBC transfusion are usually required because of hemolysis and can be brisk and recurrent until the active phase of disease has been resolved. Anticoagulation, antiplatelet, and fibrinolytic therapy is specifically contraindicated because they may increase the risk of serious hemorrhage. Plasma infusion or plasmapheresis have been supposed in patients suffering from severe manifestation of hemolytic uremic syndrome, especially CNS involvement. Another subject in our lecture is urinary tract infection. UTI is the most common genitourinary disease of childhood. During the first year of life, the male to female ratio is 2.8 to 5.4. Beyond 1 to 2 years, there is a female preponderance, with the male to female ratio is 1 out of 10. Microbiology: Escherichia coli is the commonest microorganism that's responsible for UTI in children in about 54 to 67%. Other gram-negative bacteria include Klebsiella, Proteus, Enterococcus, and Pseudomonas. Gram-positive bacteria include Staphylococcus saprophyticus and rarely Staphylococcus aureus. Less common cause of UTI in children include viruses like adenovirus and enterovirus, fungi like Candida and Aspergillus species. Classification: there are 3 basic forms of UTI: pyelonephritis, cystitis, and asymptomatic bacteriuria. Pyelonephritis or upper urinary tract infection is characterized by any or all of the following: abdominal pain or flank pain, fever, malaise, nausea, and vomiting, non-specific symptoms such as poor feeding and irritability, especially in the newborn or infant. Cystitis, which indicate bladder involvement and presented with dysuria, urgency, frequency, and suprapubic pain. Asymptomatic bacteriuria, this condition refers to children who have positive urine culture without any manifestation of infection, and it is occur almost in girls. This condition is benign and does not cause renal injury. What are the risk factors for development of UTI? We have many risk factors for UTI, which include female sex, uncircumcised male, period of toilet training, voiding disorder, constipation, obstructive uropathy, congenital malformation of urinary tract, and urethral instrumentalization. Diagnosis: complete blood picture will show leukocytosis, neutrophilia, and elevated ESR and C-reactive protein. These findings are non-specific and usually occur in acute pyelonephritis and doesn't occur in cystitis. Urine analysis, which show pyuria, which means a leukocyte in the urine, white PC count on urine analysis above 3 to 6 white PC per high power field, and it is indicative of infection. Nitrite and leukocyte esterase usually positive in UTI. Urine culture. To make diagnosis of UTI, urine must be cultured, and we have several ways to obtaining urine culture. The first method, by midstream urine sampling. This sample is usually obtained in toilet-trained children. If the culture show more than 100,000 colony of single pathogen, it is considered as UTI, or 10,000 of colony of single pathogen in symptomatic child. Another method is adhesive sterile collection urine bag, and usually used for infant, but has problem of contamination. Negative result will exclude infection. Another method is catheterization, and the fourth method is a suprapubic bladder puncture, which is an invasive technique for obtaining uncontaminated urine sampling. Treatment: cystitis. Cystitis can be treated by a 3 to 5 days course of therapy with trimethoprim sulfamethoxazole 6 to 12 mg per kg per day in a 2 divided dose, or nitrofurantoin 5 to 7 mg per kg per day, or amoxicillin 50 mg per kg per day for the same period of the time. Acute pyelonephritis can be treated by 7 to 14 days course of broad-spectrum antibiotic such as ceftriaxone 50 mg per kg per day, or cefotaxime 100 to 150 mg per kg per day in 3 to 4 dividing dose, or use of a combination of ampicillin 100 mg per kg per day plus gentamicin 3 to 5 mg per kg per day. Prevention of recurrence of UTI. We can prevent recurrence of UTI by use of drug, and these drugs including trimethoprim sulfamethoxazole or nitrofurantoin. This drug given at 1/3 of normal therapeutic dose once daily. What are the indications of prophylactic antibiotic? The indication for prophylactic antibiotic include neurogenic bladder, urinary tract stasis and obstruction, vesico-urethral reflux, and stones. Follow-up evaluation of recurrent UTI. We can follow up a patient with recurrent UTI by urine culture. Urine culture should be performed 1 week after the end of the treatment, and because the UTI has tendency of recurrence, we follow up the urine culture in the first at 1 month interval and then at a 3-month interval for 1 to 2 years. Second, by imaging studies. The goal of imaging studies in children with UTI is to identify the anatomical abnormality that predispose for infection. These studies include: first, renal ultrasonography, which can rule out hydronephrosis, renal and perirenal abscess, and pyelonephritis and renal scar. This renal ultrasonography with the hydronephrosis. Second, voiding cystourethrogram. It usually performed 2 to 6 weeks after UTI. The most common finding is the vesico-urethral reflex. This is the normal voiding cystourethrogram. Another one show reflexes, vesico-urethral reflexes due to recurrent UTI. Third, by use of DEMSA scan. DEMSA scan is the most sensitive method in detecting the renal scarring that occur after UTI. It also assesses the size, the shape, and position of the kidney, and we can also follow up the patient by CT scanning, which also assesses the size and the shape and position of the kidney and can detect a renal scarring. This picture will show DEMSA scan with a scar in the superior and inferior wall of the right kidneys. For more information, you can refer to Nielsen textbook of pediatric and illustrated textbook of pediatric, and thank you for your